So, good evening, everyone. Welcome to the prostate cancer updates from Bayer Oncology, Bayer Pharmaceuticals. I heartily welcome everyone for this Elite meeting, Elite Connect through this for today's, especially at evening, early evening. Uh, this is Rajshekhar, and I am from Bayer Oncology. As a Bayer, we strongly believe in research as well as sharing science. With this background, actually, today we have two eminent speakers, Dr. Vishwajit Pai and Dr. M.R. Kaushik. So I would like to just give a small introduction about on this of these two eminent speakers. Dr. Vishwajit Pai is a consultant medical oncologist from Aster Hospital, Bengaluru, and he has done several work in both oncology as well as hematology. Uh, Basically, sir has got a good, and he was being recognized for basically academic awards. One of the few of the main thing is he has got award. He was being awarded 8 gold medals for academic excellence and university topper in various subjects, especially while during MBBS. That too from Dr. APJ Abdul Kalam, who was uh, President of India then, actually. Uh, Not only that, he was being awarded for a presidential gold medal for most student, uh, outstanding student during his studies, and also he has received a IMPOCon medical gold medal for academic excellence and a topper, especially during his MD days. And this list will go on. And sir is also a principal investigator and primary investigator in several clinical trials, and he is also member in ESMO, ISMPO, and MASCC as well. So, sir, I really welcome you for this today's presentation. And we have our other eminent speaker, that is Dr. M.R. Kaushik. He is a consultant medical oncologist from Command Hospital, Bengaluru. Sir, to be frank with you, I would like to tell, first of all, as a doctor, it is really a great and noble profession. That too, when you are part of our Pride Defense, we would be really once again happy. We are very proud that you are also part and serving our defense sector. Thank you so much, and welcome for today's session. Sir, the flow will be like Dr. Vishwajit Pai will be having his talk, followed by Dr. Kaushik will be having his talk. Sir, dais is for you. I request you to kindly share your screen, sir.
Thank you, Rajshekhar. Thank you. Thank you so much. My slides visible?
Yes, sir. It's visible. It's visible.
Okay. Fine. Good evening, everyone. Thanks, Bayer Pharma, for organizing this meet. And I also thank Dr. Kaushik for joining this meet. So I'll quickly take through the current management of hormone-sensitive prostate cancer, special emphasis on the ARASENS trial that we're going to very briefly discuss. ARASENS is a very detailed trial with lot of study endpoints and lot of information. And prostate cancer as such has had so many landmark clinical trials that have shaped our current clinical practice. I will be spending a couple of minutes on the couple of these landmark trials like Charter trial, Stampede trial, etc. Only discussing very few important bullet points on what are the conclusions from those trials. Okay, so These slides are provided by Bayer Pharma, and I am presenting as such. So this is the overall natural history of prostate cancer. Initially begins as a localized or a locally advanced prostate cancer. If treated at this point, that's the first point, after a few years, there will be begins as a biochemical recurrence and eventually progressing to a frank clinical recurrence. The biochemical recurrence leading to subsequent clinical progression. Just yeah, I'm sorry for the interruption. So, so the biochemical recurrence, when it progresses to a frank clinical progression, it can either progress to a hormone-sensitive recurrence or a CRPC setting. Both ways are possible. Most of the times, it does happen to have a hormones HSPC itself. And if we treat at this point of time with ADT and various other treatment, we will be able to withhold the progression of the disease for a few years before it progresses to frank CRPC. And once a patient has been diagnosed with metastatic CRPC, in spite of all the treatment options available, the median overall survival is anywhere between 6 months to 15 months. So it depends on how well the patient is able to tolerate the treatment and is responding to the treatment. So the eventual endpoint in the natural history of prostate cancer is development of CRPC. So our whole aim is try to delay the onset of CRPC to as late as possible. So if a patient has been diagnosed with a HSPC at some point of time, our responsibility is try to alter the course of disease, try to make sure we treat the patient well at this point and delay the further progression of disease to CRPC. So this is a plot from the STAMPEDE trial. So what would happen if a patient with hormone sensitive prostate cancer has been diagnosed metastatic disease and he is treated with only ADT? With only ADT, the median onset of progression is about 11 months. Yes, less than an year. But we have the various treatment modalities where we can delay the onset or make sure we improve the overall survival by various treatment options. So we are going to discuss all of this subsequently. So this is from the STAMPEDE trial. So what does the STAMPEDE trial actually gave us the definition for the burden of disease, and it clearly defined that patient who have low volume or high volume disease. So if we are able to treat patients in a low volume disease, they tend to have a much better survival as compared to patients who have an extensive disease. Unfortunately, we do see a lot of patients where almost every body has been studied, every bone in the body has been studied with extensive metastasis. It's not a uncommon scenario, but the STAMPEDE trial proved this, in fact, that when you actually treat patients with low volume disease, their results are much better. So this is the evolution of treatment from only docetaxel or from only um, uh, ADT. We have reached to a point, we have improvised on our treatment. We have better hormonal treatment agents. We have better receptor blockers. So what started as GETUG, CHARTED, STAMPEDE, over a period of time, you can see progressively we are able to improve the hazard ratios are seen progressively to improve from development of abiraterone, enzalutamide, apalutamide, and currently the current standard of care, that is darolutamide. So let us go through each in one slide each. So this is the role of docetaxel. Docetaxel, as we know, has to be used in only high volume disease. High volume disease, when docetaxel is combined with ADT, a significant improvement happens in the overall survivals, 34 months versus 51 months. Whereas when used in low volume disease, it is in fact found to be more harmful. So hence, if patient has low volume disease, we try to treat them only with ADT or ADT with one of the ARPIs. Next drug we were discussing is abiraterone. We know that abiraterone, data for abiraterone comes from the Latitude trial, where ADT, when combined with abiraterone, significantly improves the overall survival from 36 months to 53 months. Okay, so this also was found to delay the development of CRPC. This is what very commonly we continue to use abiraterone with ADT. But we do know of the various adverse events that are associated with abiraterone, be it because of the corticosteroids or because of abiraterone itself: hypertension, hepatotoxicity, hypokalemia, fluid retention, etc., which will be encountered at various points of treatment with abiraterone. With regards to the third drug, that is the apalutamide, the data for which came from the Titan trial. So this significantly improved the overall survival as well as the progression-free survival. So both in the low volume and high volume groups, you can see the hazard ratios 0.48, 0.65, etc. So yes, a very good drug again in patient with HSPC. How about enzalutamide? Enzalutamide also, yes. So more or less a steady improvement we can see from docetaxel, abiraterone, apalutamide, enzalutamide, etc., to a point that we have come to discuss darolutamide. So I'll just come to that. Before that, I'll just take you through the PEACE-1 study. So this was a very unique study. Not many times do you actually get a 4-armed clinical trial these days. So this was between 2013 and 2018, which the 4 arms included patients with de novo metastatic disease patients of CSPC. Patients who had M1 disease or prior chemotherapy were excluded, and they were again classified into high volume and low volume disease. Other inclusion criteria was if they had received ADT, it has to be less than 3 months. And the stratification was based on the ECOG, the presence or absence of visceral and bone metastasis, the type of castration, whether they had received medical versus surgical, and if they had received docetaxel or not. The 4 arms were standard of care, that is ADT. Actually was only ADT, but later on during the study, they actually amended the protocol to make it as docetaxel with ADT was also considered standard of care. The other arms were standard of care with radiotherapy, standard of care with abiraterone, and standard of care with radiation. So would you want to treat patients with radiation and metastatic disease? That was what was addressed in PEACE-1 study. So high volume disease, yes, definitely abiraterone significantly improves us. Not so much because in the low volume disease, because both the studies, the median PFS was not yet reached. So coming to the discussion of the day, that is the ARASENS study. So this was a global randomized phase 3 clinical trial. Patients had hormone-sensitive prostate cancer. They had to be in good performance status. They had to be candidates for ADT as well as docetaxel. And the stratification of disease after randomization was whether they had M1, M1B, or M1C disease, and based on the alkaline phosphatase level. The randomization was between docetaxel with ADT with darolutamide versus docetaxel with ADT and placebo. So darolutamide was administered at 600 mg twice daily dose. and the study happened between 16 and 18. Data cutoff was 2021. The primary endpoint was, of course, overall survival, and a lot of secondary endpoints, if you can have a look at it, because not just survival, we also need to look at the process of delaying the onset of CRPC, as I said. So time to development of CRPC, time to pain progression, symptomatic skeletal related events, time to first symptomatic skeletal event, time to initiation of subsequent anti-neoplastic therapy, time to worsening of physical symptoms. So a lot of unique endpoints were considered in this study. So as against popular notion, 87% of other patients actually received docetaxel. We do hesitate to use docetaxel in the initial setting, but this study should all encourage us all to start using this triplet, which is the current standard of care for our patients. So the Arasens, this is a primary endpoint, the progression, the overall survival, as you can note, was significantly different, 50% versus 63%. So achieving overall survival benefit of 13%, absolute benefit of 13% is indeed an exceptional result. So the median survival was about 49 months versus not reached in the darolutamide arm. Benefit was seen in both the high risk as well as the low risk subgroups, which are seen on the graphs on the right. So these were the other the other secondary endpoints that I had mentioned. First one was time to development of CRPC, again, wide apart curves. Time to subsequent initiation of antineoplastic, the curves are separating right from the beginning, and again, wide apart, hazard ratio of 0.39, 0.36, etc. Time to pain progression. Pain is a significant issue, not only because of disease itself, but of various reasons. So pain progression is also considered a unique endpoint here, and first skeletal related event. So in all of these subgroups, all of these secondary endpoints as well, the triplet therapy with darolutamide fared much better. So one other important endpoint that we all need to look at is not just normalization of PSA. We also need to look at how many of the patients are reaching an undetectable PSA level or a level below 0.2. So this is something like in CML where we want deep molecular response. So we would want a deeper response in our patients. So this was actually correlated in a post hoc analysis to see that there was patients who had undetectable PSA levels at 36 weeks did far better than patients who had detectable PSA levels. This not only was with regards to PSA progression or development of CRPC, but also with regards to overall survival. So the aim should be not only to achieve normalization of PSA, but also try to achieve undetectable PSA or a level less than 0.2. So this is, I think, the overall survival. Overall survival also is better in patients who had undetectable PSA. Time to progression of PSA, again, the undetectable group significantly does better. So you can also see in the this bar chart, patients with darolutamide who have had undetectable PSA, the proportion is much higher as compared to placebo. So a couple of things to consider before we wind up my session and we head to the next session by Dr. Kaushik. Always look at the fitness of the patient and assess the patient's performance status and his ability to tolerate docetaxel. So achieving or administering full dose might not be practically possible in all of the patients, but at least we have had our own share of dose modifications and or administering a kind of a flat dose or a weekly regimen, though there is not really a great evidence for that. But with regards to the very elderly and the frail patients that we get, always try to incorporate docetaxel in our patients who have high volume disease. Assess the extent of disease. based on the criteria provided about high risk, not only the risk but also volume. So the risk involves high PSA, infiltration of seminal vesicles or non-pelvic bone involvement, and high volume disease involves very high PSA and development of visceral metastasis like liver or the lungs. So we need to always consider the likelihood that there will be some kind of a lot of hormone insensitive clones that will kind of come back to us and bite us in the back, and will be the most difficult things to deal. So always try to consider treatment of hormone insensitive clones. Consider the age and life expectancy. If the patient's life expectancy is not really less, are not really good, and he is in good performance status, many of the times these patients are only for surveillance. But if they are in good health, the age is suitable and life expectancy is good, if they have no other coexisting comorbid conditions, always try to hit hard and early, because or else in the years to come, prostate cancer or CRPC is what is going to eventually lead to death. So will docetaxel be an obligation in the near future? More or less, we wish to try to administer docetaxel when the patient is in good health. Administering compromised doses when the patient is not in really good health is not a really option. Try to hit hard beginning itself, so that later on we need not have to deal with the problem of resistance. And always take informed decisions. And because we are spoiled by choice, so many treatment options, we need to have informed decisions with our patients about the best treatments that are possible. I thanks Bayer Pharma and Rajshekhar for this opportunity. I'll stop sharing my slides now.
Thank you, sir. Thank you, sir. Sir, thank you, Dr. Vishwajit Pai. Dr. M.R. Kaushik, I request you to kindly share your screen.
Good evening, everyone. Rajshekhar, my screens are visible?
Yes, sir. Yes, sir. It is visible, sir. It is visible. And you can, enlarge the screen, sir. It is. Yes. Yes. Thank you.
Thank you, Dr. Shah, and thank you, Dr. Vishwajit, sir, for that lucid talk and setting the ball rolling. So, continuing ahead with the same topic and the talk, I will be talking about the ARANOTE evidence, basically with the darolutamide doublet therapy without the chemotherapy backbone, which you have discussed. So, these are the disclaimers, and slide courtesy is by the Bayer. So, as flashed on, we have seen that how the treatment of metastatic hormone-sensitive prostate cancer has evolved, and the Dr. Vishwajit sir has brought it across the data also, so, how the ADT doublet benefited, and latest by the triplet of the both PEACE and DARASONS. So these are the sequences, how it evolved, and lately we have the triplet we have been using for the last 3-4 years, and now we have the doublet combination also for those who are not that eligible for this triplet combination therapy. So basically, there was an unmet need in this subset of patients who are metastatic hormone-sensitive prostate cancer, where there was a need for balancing the efficacy and the toxicity, because we know, as well said, adding the chemo docetaxel at this age group is not easy. So there was a balance required for this efficacy and the toxicity. So we have seen the ARASON data, overall survival benefit, and then we have this ARANOTE trial coming up, where it was seen that darolutamide in combination with ADT, where we would be able to achieve this efficacy benefit and with the favorable safety profile. So we'll go ahead with this data. We'll see how this data. So background of the study was based on the ARASON data. The ARANOTE was designed to evaluate the doublet combination of darolutamide with ADT vis-a-vis ADT to provide a new treatment option in the subset of patients who are metastatic hormone-sensitive prostate cancer. So this was the trial schema. It was a double-blind randomized phase 3 placebo-controlled study. So it was total of around 600 odd patients, 2:1 randomization, all metastatic hormone-sensitive prostate cancer confirmed histologically, good performance status 0 to 2. And stratification was based on the metastasis, visceral metastasis, and volume of therapy, and some of them has received the prior local therapy. So randomization was 2:1 with the darolutamide and the placebo was ADT, that is a placebo arm. The primary endpoint here was radiological progression-free survival and multiple secondary endpoints from ranging from the oral survival, or the time for the next subsequent therapy, and time to take for castrate resistance and PSA progression, or to achieve the undetectable PSA. So it was important is because the crossover was allowed in this trial, and there was 100% crossover seen. And the selected endpoint that later after the crossover was overall survival and the safety. So in the data cutoff was seen in July 24, and the median follow-up was achieved for approximately 2 years, that is 25 months approximately, in the both the groups in this Sarah design. So coming to the basic demographic, it was well balanced, and the important for us was the representation by the Asian subset from both the race and the aging. It was around 30-32% representation from the Asian subset. Majority had a Gleason score of more than 8, to the tune of 70%. Mets, de novo Mets was to the tune of 3/4 patient had a de novo metastasis 70%, and the high volume disease of approximately 70%. So prior local therapy was seen in around approximately 15 to 18% of patients. Comparatively to other data, what we have, it can be any other doublet data in these settings. What's the difference with this trial was particularly the representation of our Southeast Asian subset, where Indian representation was seen in 13% of patients, 13 to 15% was represented with Indian subset. We had this trial enrolling in India too. So it makes a difference because almost like it can be applied towards the real world evidences. So coming to the primary endpoint, which is the radiological progression-free survival, this doublet of darolutamide and ADT significantly reduced the risk of radiological progression to the tune of hazard of around 0.54, that is 46% reduction in the radiological progression-free survival compared to only ADT arm. The follow-up achieved was 25 months, and we can see in this 25 months the trial arm, that is darolutamide ADT, it was not reached. The radiological progression-free survival was not reached. So with this significant hazard, you can see the separation of the curve starting from 2 to 3 months. There was a wide separation of the curve. So there was a significant reduction in the risk of radiological progression with this doublet therapy of darolutamide and ADT. And important is the benefit was seen across all the pre-specified subgroups, and particularly what's important is both the high volume and the low volume. Across both this high volume and low volume, the benefit was consistent, though the numbers of the low volume are on the lower side, but high volume had a sufficient number, and the benefit was seen with a hazard of 0.60 in this low volume subset. Even though the visceral metastasis had some benefit, but importantly, the disease low volume had a benefit across these doublet arms. Another was darolutamide. The benefit was also seen with respect to the OS data at this end of cutoff was immature per se. And though there was a clinical benefit in this arm, but the OS was immature. But coming to the time for progression to metastatic castrate-resistant prostate cancer, or the PSA progression, or the initiation of subsequent systemic therapy, and also the pain progression, everything, all the subgroups benefited with this doublet combination of darolutamide and ADT arm. So these are the secondary endpoints what we have seen. The time to metastatic CRPC. It has seen this doublet combination delayed the time to metastatic CRPC. In the ADT arm, it was 13.8 days, which was not reached in the doublet arm. Important is the time to pain progression, as stressed by the previous speaker. So in the ADT arm, it was approximately 30 months, and the darolutamide arm, it was not reached. So this is the one endpoint I feel it's important because it affects the quality of life of the patient. So with this doublet arm, there was a delay in the significant delay in the time to progression, which is high important seeing the quality of life of the patient per se. Coming to the achievement of the PSA response, which is undetectable PSA response, yes, almost it's to the tune of 63% in this doublet arm, when compared to the ADT, it is approximately 20%. And also time to PSA progression also, it was with a hazard of 0.31, there was a significant delay in the time to PSA progression with this doublet arm. Also, when you see across both the high volume and the low volume disease, yes, across the time form, there was a significant improvement when compared to the ADT, as it was almost 2 to 3 times improvement in achieving this undetectable PSA in using this doublet or combination of darolutamide and PSA. And the subsequent anti-cancer therapy in the both arms, yes, definitely ADT is 40% the patients who were in the only ADT arm progressed for the second line of therapy. But what's important in even in this doublet arm of darolutamide and ADT, approximately 30% of patients did receive the subsequent therapy, and in those 20% went on to receive the chemotherapy, that is docetaxel, and further with all the further combinations or other available data. So it's still the same subsequent line of therapy. Significant patients received the subsequent line of therapy per se. Treatment-related adverse events, which we are now more emphasis has been given to balancing the toxicity because of the long-standing disease and long quality of life, which is to be important in these set of patients. It was seen in this treatment duration, the follow-up of approximately 2 years. The treatment-related adverse events are similar between the both the ADT and the doublet combination. Another important is the treatment-related adverse events linked to the permanent discontinuation of the darolutamide or the doublet arm was on a lower side actually when compared to the ADT. It was 9% in the ADT, but it was surprising it was 96% in the doublet combination. And coming to the adverse event per se, related to the ADT, more than 5%, which is commonly occurring, whether it is attributable to ADT, it was almost similar between those of a doublet arm and the arm with only ADT, be it anemia, bone pain, hot flushes, pain extremities, and surprisingly, the few adverse events like a fatigue was the incidence was lower in doublet arm compared to only ADT arm. So other adverse events which was associated with the ARPIs, cardiac-related arrhythmias, hypertension, the bone fractures, mental impairment, seizures per se. So these were almost all similar across between these two arms. There was no big safety point which was seen in this. So majority of the adverse events were equally seen with these both the arms which has been seen. And the most important one being the quality of life per se. So health-related quality of life as assessed by the FACT score, it was seen this doublet combination of the darolutamide along with the ADT extended the median time for deterioration based on this FACT score to approximately to the tune of 5 months. So there was a 5 months prolongation in the deterioration of the health-related quality of life. So overall, when we see this doublet combination, it resulted in the meaningful delay in pain progression and overall well-being. And when we see looking into the particular other domains of this FACT score, the benefit was seen majorly. It was seen in across social and family well-being, functional well-being, and also towards the urinary-related symptoms with this doublet combination. There was a overall improvement in this health-related quality of life, particularly in these domains per se. So with this, we can summarize that this combination of darolutamide and ADT, it significantly improves the radiological progression-free survival in the patients with the hormone-sensitive cancer. And importantly, the benefit was seen across all the endpoints, this being the primary and the secondary endpoints. And this combination achieved a deep PSA responses regardless of the baseline PSA. So this the combination improved the health-related quality of life, particularly with related to the pain progression, well-being with related to the domains of family well-being or social well-being, functional well-being, and urinary symptoms. And the favorable safety profile is well tolerated, almost similar with what we are seeing with the ADT therapy. So as we said, we are spoiled with choices in this setting of metastatic hormone-sensitive prostate cancer, and now we have definitely we have additional combination of this doublet of darolutamide and ADT as others can be become as another additional standard of care in the setting of metastatic hormone-sensitive prostate cancer. So thank you, Rajshekhar and Bayer for the opportunity. With this, I conclude this talk and over to the organizers, please.
Thank you so much, sir. Thank you very much. It was a really nice presentation from both the speakers. Sir, just we will try to understand if there is any questions or any discussion or any questions from our audience. Audience, if we have any questions, we can shoot now. Or you can even post it in the chat. Sir, actually, there is one question which has been posted. So one of the doctor is asking that, can we use chemotherapy, that is docetaxel or cabazitaxel, after the progression of darolutamide?
Yeah, Rajshekar, definitely yes. Previously with the we know the second line usage of the chemotherapy has always been a practice until we got this triplet combination of both your Erasmus and Peace came into the picture around 3 to 4 years back. So previously it was a standard of care. We start with the doublet, and then once there is a progression, we go with the taxanes, particularly the docetaxel. Then being a taxane, we have that benefit of re-exposure of the taxane, that capacity. So exposure to the taxane is always, we have the data and evidence for that. So definitely yes, if the patient is fit enough, in the second line, definitely we have an evidence for using these taxanes.
Thank you so much, sir. Thank you so much for sharing this. And any further questions if you have? I think so. I conclude that most of the audience have understood everything, and thanks for sharing the updates on prostate cancer. Thank you, Dr. Kaushik, as well as thank you, Dr. Vishwajit Pai. And it was a really great discussion on the updates on prostate cancer. And it is not only to be sharing about the efficacy of the drug, but also safety profile. Absolutely, it is very, very nice to hear. And thank you so much. Thank you so much for this session, and we'll certainly continue the sharing of knowledge from Bayer. Thank you so much. Thank you very much, audience, as well, and thank you very much, evidence speakers, once again.
Thank you, Rajshekar. Thank you, Dr. Vishwajit. Thank you, everyone.
Thank you, Dr. Kaushik sir. Thank you, Vishwajit sir. Thank you.
Thank you, sir.
We are offline.